tumors, current approaches and treatment of benign brain tumors. May I now invite on the stage our esteemed chairpersons, Dr. Charu Garg, Director, Radiation Oncology at Max Institute of Cancer Care, Saket, New Delhi, Dr. Prakash Shetty, Consultant Neurosurgery at Tata Memorial Hospital, Mumbai, and Dr. Kamal Verma, Director, Department of Neurosurgery, Sarvodaya Hospital and Research Center, Faridabad. Please welcome on the stage. I have one small announcement to make. We have a preliminary round of quiz happening at 11:30 a.m. in Hall B. Whoever is interested can join there. Now I request the chairpersons to please invite the speakers.
Yeah, good afternoon, everybody. I would like to invite for the first talk Dr. Ashish Suri from All India Institute to talk on petroclival meningiomas. So he is a magician in this area. I would say petroclival areas, even for a young neurosurgeon, is just like teaching the anatomy of internal ear to an MBBS student. It's so confusing, but he makes it so clear. And 3D orientation, we have been learning from him since our early residency days. Sir.
Thank you. Thank you, chairpersons, and congratulations to Dr. Indu and Dr. Aditya for a wonderful conference. And let me be very frank, this is nothing to do with good tumors. I think I saw the heading as good tumors. This is probably a nightmare for neurosurgeons. And actually, if I must tell you, and the more I do them, the more closer to God I become. So Dr. Ashish Pathak is waving his head. So these are one of the most challenging tumors. And this is the area which we are talking about. This is the area which is the upper clivus, the petrous, and there's a big extension. And these are predominantly, these are the ones which need a proper anatomical, radiological consultation because they are centered on the petrous apex. And that is the area which, marker there. Yeah. And this is the area which we are talking about, the posterior clinoid, the petrous apex. That is the area. And these are centered around the fifth nerve, and below we have the seventh, eighth complex, and above is the third, fourth. So that is the extent, and the cavernous sinus and the complete cavernous sinus. They constitute around 3 to 10% of posterior fossa meningiomas. They're benign, slow-growing, encased neurovascular structures. The biggest problem is they are stuck to the brainstem at least 10 to 20% of times. So surgical excision becomes mandatory because they invaginate that they are close to the perforators. So ultimately, radiation therapy also becomes a guarded therapy. They are very high operative as such, and even natural history of morbidity and mortality. What is the optimal surgical approach? There have been quite a lot of them, and we've tried all of them. It can be the retrosigmoid approach, Kawasai's approach. There can be other approaches like modified Dawlin-Kawasai. I use the one in blue, that the standard retrosigmoid, the modified Dawlin-Kawasai, the modified Dawlin-Kawasai, along with the retrosigmoid. I don't do a complete petrosal approach now. And this is the extent, if you see the Towers classification, region A, B, C, D, E. This is the area, that is the whole middle skull base and the posterior skull base can be. This is the area I'll be talking about, the posterior triangles, that is the posteromedial or the Kawasai's triangle, which our team actually modified into a Dawlin-Kawasai rhomboid and with the cavernous sinus modification. And this is the standard approach. If the tumor is more posterior, that is centered around the petrous apex, it is like a temporal approach, an extended temporal approach. But if there's a cavernous sinus extension, it becomes like you have a more anterior orientation to that. And I usually do a temporal craniotomy with a zygomatic osteotomy along with that. But if required, but most of the cases, some of the cases, maybe 10% of the cases, if there's anterior modification, we can do a FTOZ. This is a standard FTOZ craniotomy. It's a small cranial or a temporal craniotomy with a small temporal craniotomy with a zygomatic osteotomy. This was the standard Kawasai's triangle that we know of. Because of lack of time, I will not go into the anatomical details, which we actually convert into a rhomboid. And if you see, this is the petrous apex that I'm talking about. So we are centered there at where the tumor will be taking the origins from. And we did a volumetric study compared with the other approaches like the standard Kawasai, the Hakuba, as well as the Shekhar's approach. And we found that this approach had a better, had much more volume in area, nearly 2.5 times, which was published around about, say, 7-8 years ago. And the good thing about this approach is that you can actually mobilize the fifth nerve, and because the tumor is centered over the fifth nerve, so you can take out the tumor in the cavernous sinus, over the tentorium, go into posterior fossa and the middle skull base. And the nerves which are most sensitive are the sixth nerve and the seventh nerve, which you can actually injure. So with this approach, they are the ones. What are surgical adjuncts? Surgical adjuncts are very simple. You need long forceps, you need fine tipped forceps. So, and you need some navigation, you need some Doppler, and a good microscope. This is a video which was accepted just a few months ago by one of our, I can't forward this. You'll have to help me. Thanks. Shall I come there? This is the video. But it doesn't have a scroll line, right? If I play this, I can play this, but it'll take a. This is the next video. जब उसको चलने दो, हम बीच में बंद कर देंगे, फिर नेक्स्ट आ जाएगा। तो जब आप 1 घंटी बजाओगे तो हम बंद कर देंगे। नहीं और इसको प्ले कर दो। This was a recurrent one. It was operated elsewhere, and they did a standard retrosigmoid approach. Remove 5% of the tumor. I think the brain was bulging. They referred to us, and this was a difficult case. And initially, I used to get a lot of recurrent cases. Initially, I used to do a lot of post-irradiated tumors and post-gamma knife, but I've stopped doing that because once you irradiate these tumors, they become surgically inoperable practically. So you have the first time is the best, and even the second time is the best unless it is radiotherapy is done. So this is the extended temporal approach, and that is the dissection of the posterior cavernous sinus and dilation of the foramen spinosum and the middle meningeal artery. The standard temporal craniotomy, you're actually making into an extended temporal approach. If the tumor goes beyond the internal auditory canal, you actually do. I actually combine a retrosigmoid approach along with that. Then peel the lateral wall of the cavernous sinus. That is the sharp dissection of the GSPN. The whole cavernous sinus is peeled off. So this is purely extradural till now. I'm sorry, I cannot forward this, so we'll have to bear with me. And then the middle fossa triangles and the drilling of the posterior rhomboid is done. And that is the petrous rhomboid. If you see, that was the original triangle which you've converted into a rhomboid. And this is the petrous apex. That is the cavernous sinus. That is the ganglion ganglion, petrous ridge, arcuate eminence, GSPN. And we're drilling the petrous apex. The drilling is right from the internal auditory canal that will underlying this. That is the arcuate eminence underlying the semicircular canals. That is the internal auditory canal. That is the ICA, the Glasscock's triangle. So we take off this rhomboid there. So with this approach, the tumor is directly under this. So you've already devascularized quite a lot of tumor. So do a basal temporal durotomy. And now the part of the tumor is already devascularized. That's a good thing about this approach. Rather than retrosigmoid, or because then there your tumor is not devascularized at all. So you're right on the tumor. So here you have to be careful where exactly the fifth nerve would be. Anatomically, the fifth nerve would be just bang in the middle. So we are cutting the tentorium and the superior petrosal sinus. So the posterior fossa is opened. Decompress the tumor. So now you can debulk the tumor and later dissect. This is the standard retrosigmoid approach, which I do only in complete petrosal meningiomas. You actually dissect first and then decompress later. So that is the difference. And then here you can, at the end, you have a thin sleeve of tumor. You can decompress from the 6th and the 4th nerve here. But the 4th nerve. So the extent of the tumor is right from the 3rd till the 7th, 8th. If it goes beyond the 7th, 8th, then you need a retrosigmoid along with that. You separate along from the brainstem and perforators. But that is the problem with these tumors, because it's usually stuck to the basilar perforators and vaginate into the brainstem. The gamma knife is practically the only therapy for residual. And then even we've seen a lot of cases who have pile invasion and they have brainstem edema. That's the 6th and the 5th nerves and the 7th, 8th complex. And that's the basilar trunk. I think we can go to the next one. Preservation of the 5th cranial nerve that we can monitor and close the dura, put fat. There's hardly any risk of CSF leak because you're not opening all the temporal layer cells. And that's complete excision. I'll skip this video, and we have some, just to show some pre or post-op cases. The aim is not gross total. The 2/3 of my cases, we've achieved gross total to near total, but yes, subtotal can be there. Now I'll speed up because the bell is there. So we have some more cases of pre-op, post-op, and some near total, and this was another near total excision. This was in the one in which we left some remnant over the cavernous sinus. That is a difficult one to do. That is good for gamma knife or any other radiosurgical procedures. And this is the one in which it goes lateral to the internal aortic canal. We combine a retrosegment along with that. And so that is the complete excision in this approach. So my personal series around 50 cases. Primary cases 43, previously operated 7. And gross total we did around 33 and subtotal around 17. I lost 2 patients, one in the recurrent group and one in the primary group. And follow-up MRI revealed complete excision in these cases. The small residual tumors were given gamma knife therapy or external beam therapy. Radiosurgery was done in 3 for recurrent tumors. We realized that 6th and 7th cranial nerves showed significant persistent deficit on long-term follow-up. So these tumors can be silent, they can involve cranial nerve deficits, but these cranial nerves can become permanent if the 6th and 7th are involved. And the lower cranial nerves and the cerebellar signs show significant improvement on long-term follow-up. We realized that the volume of the tumor, the cavernous sinus extension, hydrocephalus, contralateral extension, cellular extension do not have any role to play in the extent of resection. But yes, T2 hypointensity, which we realized, and the brainstem edema, these are the 2 features that are. This is a linear plot. We realized that the presence of both T2 hypointensity and brainstem edema was going in straight for a subtotal resection. But here I have this, there are a lot of talks about why can't we do a tailored resection and then subjected to gamma knife or any other therapies. But I think it is very difficult to do a tailored resection and measure that you're leaving 5% of the tumor. I think all the skull-based surgeons will agree with me. Once you are in the tumors with all the navigation techniques, and this is something that probably we are first time in the literature we are doing. This is, we realized that 20% of our tumors who had subtotal resection and had 1p14q core deletion. And we did molecular markers after the new WHO classification, the H3AM27E ME3 loss, CDKN2A deletion, PTERT, AKT1, and SMO mutation. And we realized that both these cavernous sinus extension and brainstem edema were directly related to the CDKN2A deletion and the H3KM27 ME3 loss. And regarding more of the molecular markers, you can consult my better half because I think that the WHO classification keeps on changing every year. I've got lost track of it. I used to learn from my better half as well, and impress my residents and my colleagues. But I think WHO have lost it. So I think they keep on changing. So I think in this, you'll realize neurosurgery is the only thing that is static. We are probably the Shiva. So everything is changing, but except for neurosurgery. If you see all the series from way back from 2000, 1990s and the 80s, and realize that the extent of resection is the same. If you compare our series with literature, it's the same. It is, yeah, some series are worse, but they're talking about gross total. But you cannot really measure gross total in cavernous sinus. So it is 2/3 is gross total to near total, and 1/3 is subtotal. And the adjuvant therapies have been the same. The mortality is the same. And I'm talking about the last 30 years. And this is a meta-analysis which was published and which revealed similar findings. And to conclude, our MDK approach, which is a good extent of resection with acceptable results. T2 hypointensity and brainstem edema predicts the extent of resection. It is goes with the poor extent of resection. 1p14q correlation associated with the less extent of resection. And H3K27 Me3 loss and CDK into a deletion might affect the prognosis. And as per my fellow who was analyzing this, he said that these are the at least for Petroclival Meningiomas, we are probably the first center who are reporting these molecular markers with the extent of resection. Thank you.
Thank you, sir.
Thank you.
15 years, probably something, 20 years, at least 20 years. And that's from, from the giants of meningioma surgery. So, and even the Simpsons grade 1 has a 9% recurrence.
Yes,
sir. So no matter what you do, they are going to come back someday or the other and different form. And they're so varied in their nature and everything is totally different. So don't put meningioma as one heading and say that, oh, it's a benign tumor. That's absolutely wrong.
Absolutely.
And I think what you said, surgical excision to the maximum is one criteria where the tumor might have a delayed coming back or you reduce the chance of coming back. That's it.
More than that, sir, I think what we have to put emphasis on is the surgical excision, and the amount of tumor that we are leaving should not be causing any more damage.
Yes.
Because once you've damaged the perforators, no amount of adjuvant therapy would actually help.
So safe surgical resection and then surveillance.
Absolutely.
That's the only answer.
Thank you, sir.
What treatment do you advise these patients if the patient has already undergone radiation, and then what other modality?
Ma'am, that is not an evidence-based statement. It was more of my personal statement. I've operated some post-irradiated tumors, gamma knife as well as conventional MRT, and have had a horrible. I've operated them for 12 hours and not results. Probably worsen the patient rather than help the patient. So I think the best thing is if there's a sizable tumor, sent to another center for reoperation. That is one. Second is if the tumor is a bit of residual on the brainstem and cavernous sinus, maybe gamma knife in my knowledge is the best. Maybe other experienced people with cyber knife as well as proton beam can give their comments on that. But I think that choice has to be there. I don't have any knowledge beyond that. I'm sorry.
Majority of the surgeons in private do not go there. They always send to AIMS or government institutions. Now, if it is more of the bitter, then it is easier to operate. If it is more of clival, it is very difficult to operate. Did you come across the patients who had majority of the clival tumors? What do you do?
Majority of the clivus, then they actually become mid-clival meningiomas and all those. And those are the ones, the approach is standard. Upper clival is same, extended temporal approach. Lower clival becomes somewhat of a modified far lateral with a transjugular or a actually, on all these approaches, I realized you have to do increase the extradural corridor.
Right. My question was whether do you send these patients directly to the gamma knife?
No.
Or
No.
Operate some?
Always operate. Okay. Always operate. The thing is that they're stuck to the brainstem. 10 to 20% of them already have T2 hyperintensity. That means the brainstem, the pile invasion is already there. So you're actually giving them radiation, and I think Tejpal and other my friends can put. I think the volume of tumor is directly proportional to how they behave after radiation. So I'm not trained in that, so I cannot. But I think that debulking and leaving a thin ring of tumor is important.
Debulking is important.
Yeah.
Thank you.
And just one more question. If you have pile invasion, would you think of doing a subtotal resection when you start the surgery, or would you still aim for a complete resection?
Was in 30 years in AIMS and 50 of these cases, I'm still not able to define when will be my subtotal and near total and gross total. So can you define now? No, I think no navigation can help. Till now, I'm not able to. I'm still learning, so I don't know. I'm unable to understand those papers who say you do a tailored 90% excision and give the last 10%. You cannot, because despite your navigations, there will be islands of tumor. There will be outpouching of the tumors. You cannot navigate the whole tumor there. And it's the worst thing about these tumors is there's a big carpet on the brainstem. There's a very big carpet on the brainstem.
And regarding the tailored resection, I think the radiation oncologists are more fearful of radiating a tumor which is near the brainstem, and this is the tumor which is generally left behind us. So if it is stuck to the brainstem, so I don't know whether tailored resection will help radiation.
Yeah, a lot of papers are coming in. I think the problem with US literature is now they promote such.
The problem, if you are going to use gamma knife, then anything stuck on the brainstem, you'll have to reduce the dose of the gamma knife, the dose that you give, which means that you have to get suboptimal control, local. I think debulking is important. The mass effect, you have to reduce the mass effect. Without that, the patient is not going to get any better. And of course, all adjuvant treatments will work better with the lesser adjuvant.
Just quickly to add, this tailored dissection is concept in the West because nobody wants to accept a deficit. That's where it comes from. The ideal should be, when it's possible, in good hands, like him, go for total dissection. If not, little bit left behind, then we can.
But they will not publish our paper, sir.
They won't do a craniotomy simply because they can't drive for 6 months. As per
That's true.
They will say, go through the nose and remove as much.
Yes. That's another nose theory coming in, big thing.
If there are no more questions, we can proceed with the next talk. Thank you, Dr.
Thank you.
Suri. The next speaker is Dr. Sushma Patil. She will speak on treatment implications of the change in molecular classification of meningiomas and pituitary adenomas. Redefine the story.
Thank you. I think I can reach, but let me try. Okay. Good afternoon, everybody. I thank the organizers for giving me an opportunity to speak on this podium on meningiomas and pituitary adenomas. And after hearing the confessions, honest confessions of the surgeon and living in a not so positive note about the WHO and Dr. Pathak's comment taken very well, it doesn't give me a whole lot of assurance to go with my talk. But I'll do the best and try to do justice for the subject that's given to me. But I would like to say, ye bahut nainsafi hai. Giving meningiomas and pituitary for 15 minutes is an impossible task. So I'll do my best. I may have to rush through slides, but I will reserve for the questions at the end. Okay, I have tried to cover the latest developments. What is known is known to most of us. What is latest only I'm going to cover in the short given 15 minutes. With that prelude, I'd like to start my talk. So what does WHO define meningioma as? A group of mostly benign, slowly growing neoplasms that most likely derive from the meningothelial cells of the arachnoid layer. Nothing sounds so assuring about its origin, but anyway, they tell us there is caveats, as explained by our clinical colleagues. So what did 2016 tell us? They gave us the whole rehash of what was already known. They gave us a grade 1, grade 2, and grade 3 meningiomas. Grade 2, they separated based on the mitotic figures and the brain invasion, which is questioned right now in large scale studies. And anaplastic meningioma was given as a mitotic index of greater than 20 per 10 high power field and frank anaplasia, and with histologic mimics of a sarcoma, carcinoma, of melanoma. So this was what we had seen in 2016. Now what has changed? What has changed is very small. Dr. Suri, WHO has not made a lot of changes in grading of meningioma this time. So they just made one addition to the already existing data, that was the grade 3 tumors. They added third promoter mutation or homozygous deletions of cyclin D kinase 2A and B. If the tumor does not meet the criteria set by the previous WHO 2016, that is 20 mitosis and more, or a frank anaplasia. So this I use whenever I see tumors that are 12 mitosis, 14 mitosis, not going all the way up to 20. What do I do? Do I call them atypical? They are more than atypical, but they are not anaplastic. This when I go ahead and do third promoter and the homozygous deletion 9p21. If it comes, I know it's anaplastic, we do it. So most of the time we ask, when do you choose to do cyclin D kinase? When do you choose to do third promoters? And a wisely chosen case will help you in getting the third promoter analysis. But I always rely more on 9p21 in these particular cases. If 9p21, which is the surrogate, which maps to cyclin D kinase 2A gene, if it is negative, then I go ahead with third promoter. But FISH is easy, gives us a quick results. I do it first and then followed by third promoter methylation. Okay, so that's how I do it. And the next is the two types of histologic subtypes, choroid meningioma and clear cell type. I just want to spend 2 seconds on this choroid meningioma, because many a times I'm seeing tumors that are labeled as choroid meningioma turn out to be something else when I do IHC in histochemistry analysis, because some of them, at least a subset, have turned out to be intracranial mesenchymal tumors, which is a DD and occurs in this location very frequently. So that is why I put this slide to show that just not choroid meningioma, something is odd about it. Please do think about intracranial mesenchymal tumor. Okay? And clear cell type usually we see in spinal cord and has SMARC4 mutations. Okay, so papillary variant falls in grade 3 by histomorphology, and rhabdoid variant, which is grade 3, also has BAP1 abnormality, which is a BRCA-associated protein 1. So there are also familial cases of rhabdoid. So just to show you that all tumors with rhabdoid morphology are not necessarily rhabdoid variants. So you have to be very careful, at least do a BAP1 analysis. If you're in doubt, if it comes positive, most likely you're dealing with rhabdoid meningioma, because they're very aggressive tumors. All right, so how do we diagnose? So there are an array of markers. I would go with only 2, EMA and somatostatin receptor 2A. These are the 2 very good markers that are likely to give us an answer to a meningioma, especially SSR2A. It's quite specific and it's wide ranging grades, it is still retained. But whereas EMA can be lost in higher grades or some grade 2s and grade 3s. So combining together, you're going to have a very good idea that you're dealing with particularly a somatostatin receptor. PR is not so reliable, progesterone receptor. Okay, it can be lost in grade 2s or grade 3s. Particularly, you should be very leery that if diffuse EMA comes positive and somatostatin is negative, you please think of intracranial mesenchymal tumor. SSR2 most likely comes positive in most of the meningiomas. The reason I'm telling you is that we have had cases, we have run into them, we have re-diagnosed them as mesenchymal tumors after we realized that it was not the case. So I'm telling you, please, whenever you are in doubt, when you have something odd about a meningioma, please consider intracranial mesenchymal tumor. It has a lot of different histomorphologic phases and it is likely to come in different forms. So that's what it is. And coming to the meningioma genetics, this is the heart of today's talk, most of it, and how it is changing, making a paradigm shift in the treatment of meningiomas. So let's recap what we already know. So we know that arachnoid capsules are likely the possible cell of origin for these meningiomas. They can give rise to directly grade 1 or grade 2 or grade 3. Grade 3 very rare, but most of the time grade 3 is transition from grade 2 to grade 3, and grade 1 to grade 2 also transitions occur, but most grade 2s start as de novo grade 2 in my opinion. And when we go and look and see the meningiomas, we have 3 different genetic patterns that we observe. One is the mutational analysis that goes into them, and the cytogenetics and the gene expression profiles. So all 3 are important in these cases. So when we see at the mutations, we can see that the low-grade meningiomas have already what is called as NF2, SMARCS, B1, KLF, TRAF, SMOOC, AKT. All those put the tumors in the grade 1 category. But if you go down a little bit, you can see losses of various chromosomes makes it into a higher grade category. And And if you go to the gene expression pattern, cyclin D kinase forms the prominent marker these days, along with TERT, that is driving the malignancies and recurrence in these tumors. Okay. So this was, there was way back, it was 2017, and before that in 2013, there were two papers that came out, particularly the 2013 science paper that talked about non-NF2 associated meningioma. Until then, everybody thought mostly the meningiomas are driven by NF2, but most often we did not know what the other subgroups were doing. So now we know that there are tumors that are non-NF driven, and they tend to be lower grade tumors, and they have site specificity as well. Then followed by this one Daimling group who came up with this DNA methylation classes, and it was pretty good paper, and they got a good concordance with those methylome classifications. So broadly, we categorize the tumors into two categories, NF2 meningiomas and non-NF2 meningiomas. And NF2 is usually likely to be atypical, then they have a genomic instability, cerebral hemispheres are preferred locations, whereas NF2 meningioma tend to be in the basal region, skull base, and then they are almost always benign, and TRAF and KLF sometimes are co-mutated in nearly all secretory meningiomas. Okay. So these are the nuances that we're getting to see. I want to spend 2 seconds on NF2 because it is important. First of all, it's a tumor suppressor gene. It maps to 22q12.2 loci. And almost all mutations, whether they're frame shift, nonsense, or the splice site mutations, they all cause truncation of nodeling. It's a protein that acts as tumor suppressor. So defective protein leads to lack of tumor suppression or and leads to tumorigenesis. So this is the main pathophysiology of NF2 gene in this meningioma that drives the tumors. And I want to talk about one second about TNF, receptor-associated TNF factor, which maps to 16p13.3 region. It is a tumor that is highly specific for meningiomas. Okay, so this is one thing I wanted to see. We don't see much in other tumors. So if you look at the landscape of the entire global landscape of meningiomas, you can see that there is two distinctions come right away. One is the major driven by 40% or so by the NF2 group mutations, and then the second is by the TRAF. TRAF can have overlapping mutations with the other three genes here, KLF4, AKT, and PI3 kinase. And you can see these forms a formidable 30%, and a small subset of 5% are SNU, and then a large 20% still remains unknown. Okay, so this is the mutational landscape of meningiomas right now. And when you consider genetics and the mutational frequency, again NF2 tops the list, followed by a smaller composition of the meningioma mutational frequencies in the other groups. And if you look at the site, Dr. Suri will be very happy. You can tell that if he is dealing with a convexity meningioma, likely to be high grade, and they can aim at a gross total if possible. And it is, I don't know about the surgical details, but that's, I am told that a recently better area to operate than the skull base. And if you look at the skull base, we can be reassuring if you leave some tumor behind, because still they tend to be a grade 1 tumors, because low grade tumors, because they have a certain mutation that's associated in these areas. Okay, so that is why you can see these tumors in the base of the skull area. And spinal cord, we have the clear cells, and the smart C1 comes into the picture. So these are the various location-based genetics that we are seeing. And if you look at the genetic alterations, also it's the same story all over again. Low grade tumors, we have this TRAF non-NF2, and in the NF2 category, we can see both grade 1 and grade 2 and 3s. Okay, so this was the chart given by the one Daimling group in their paper, and they nicely classified location, mutation assigned, and the outcomes were given in this chart here. Okay, so recently there has been two papers that came out, one in Nature of last year, and the second one that came out in last month. It was the meningioma DNA methylation profile group driven by the UCSF group published this. I will not believe, though they're presented 1 year apart, they both are showing some very common outcomes they have seen, and then they are trying to classify. Both have come up with a very similar methylome profiling groups. You can see that. So in the ALDAP group by the NCI, which was published last year, they have 4 categories: benign tumors, NF2 wild type, and in the Raleigh group, that is the UCSF group, maintains Merlin as intact in the first group, and these have a very low risk of recurrences. And the defining feature in their studies were that at least one normal copy of NF2 had to be present. And the second group is immunogenic or immune enriched, and they have low to intermediate outcomes. Then the hypermetabolic and proliferate. These are the two groups that are likely to recur very frequently and can produce mortality and morbidities. Okay, so the LDAP group, which is the one that published last year, they have zoned in on this drug that inhibits the or reverses the certain epigenetic alterations, and it is used to treat lymphoma. So this vorinostat is the drug they have zoned in, and they're going to start clinical trials very quickly. So they are focusing to target the hypermetabolic and proliferative groups, whereas the Raleigh group is going on the abscess. This is the inhibitor that they're going after, targeting the lymphoma, hypermitotic and the immune enriched groups. So there is a lot of activity regarding the targeted therapies for higher grade meningioma. This is the very latest paper coming last month. Okay, so then they also, the UCSF group has given a website where we can, if you have methylome clustering, if you have methylome analysis, you can put it up on their website and you can check whether what methylome class is your tumor belongs to. So they have, it's an open website, anybody can load their files. So, and more buzz is happening in the CK. Now the research is focused on cyclin D kinase 4/6 inhibitors and treatment. This was published last month in Frontiers of Oncology. Very, very latest off the shelf it has come. And there is a lot of buzz because you know the cyclin D kinase 2A, 2B are the drivers that put the meningioma into group 3 or anaplastic category, and they have very high recurrence rates and morbidity. So it makes sense to go after these molecules as targeted. So CK4/6 inhibitors are the one, they are cyclin D kinase dependent, and they inhibit the cyclin D through the phosphorylation of cyclin D kinase 2B through the P16 protein. Okay, so another important feature is that when you combine these cyclin 4/6 inhibitors with other pathway inhibitors such as PI3 kinase mTOR and the MAP kinase inhibitors, it produces synthetic lethality. So that means two drug combination will produce long-lasting outcomes. So there is this combinations that is being tried, and then the trials are about to start. This is the CK4/6 inhibitor trials for meningioma. One is already closed. 3 are their recruitment has started. We're including the UCSF group and the St. Jude's. So there is lot of activity based on the findings we had seen from the breast treatment profiles, clinical trials. They are looking at introducing CK4/6 inhibitors in high-grade meningiomas. Okay, so in summary, advantages of molecular classification of meningiomas are many, quite. So it helps us predict precise prediction of the clinical behavior than the WHO classification grading system, and it is substantiated by the independent validated series also are now available. And it's most notably the novel approach is capable. The novel approach is capable of identifying patients who are going to be at high risk and put aggressive therapies from the get-go and treat them with all forms of modality that are available, so that we can give long-lasting outcomes and progression-free survivals. So this approach could greatly improve the basis for clinical decision-making and whether to decide whether we have to give additional therapy after surgery or not. I think I'm running out of time for the next talk. I think I will stop here because pituitary adenoma I was supposed to start, but I don't have much time. How much time do I have? Over? Okay. Sorry, I was not able to complete pituitary. That's what I told you. It's about 9 here. So I will be taking
any questions from the floor?
Sure.
What exactly, if you want to say that it's
you can do a couple of tests. You can do fish. Okay, so fish is there. Then you can also do mutation analysis for single sequencing. You can do that because it's a very large gene, and you can have mutations anywhere. So as I said, there will be you can have mutations, but you have to make sure that the testing lab covers all the entire gene.
There is no IFC available to test for.
Not that I know of. Not that I know of. Okay.
Thank you.
You made a statement that NF2 has got chances of going to higher grade.
Yes, sir.
But then if you go through literature, 55% of these tumors have NF2 as the mutation for genesis.
Yes, sir. So because
so that's where actually probably
because they can come in grade 2s also. So we don't test them very frequently for NF2. 40% are there. So that's why I'm trying to. If we have to get a hold on these tumors, if there is something atypical about the pathologist, should be the first forerunners of requesting for NF2 mutations.
Yeah. Even if they are not atypical, even if they don't show infiltration, the 45 to 55% of
Yes.
patients have NF present.
True, sir.
mutation genesis
Yes.
in them. So
And it also the side gives you some idea of where likely the NFT mutation is like, because if you're mostly
that's
skull based,
safe,
that's,
and then
yeah,
again, there's a
exactly.
variation.
True,
So
true. Okay.
it's not absolutely the same.
Sure. So that's what it is.
We know that third promoter mutations have aggressive here.
Third promoter.
Here.
Yes, sir.
Third promoter mutation, we know that.
Yes, sir.
So when do you do third promoter mutations in the meningioma?
I told you, sir, third promoter mutations are when I have tumors that are falling in between grades. That's the best time I usually select. If it is a classical low-grade meningioma, I wouldn't want to do that. But if it is going to be grade 2, which is not fitting grade 2, it's more than a grade 2, not falling into the grade 3 categories. For example, I have 10 mitosis, 12 mitosis. It is definitely grade 2, but I have a feeling that this is definitely going to progress, or there is something bad about this which I'm not liking it for grade 2, because grade 2 means it just falls in atypical category. But are there anything more to add? So supplement the grade 2 and try if we can put it in grade 3 category now with the third. This is when I would definitely ask for a third promoter, but first I would go ahead with doing cyclinic kinase 2A to B first. So that is a simple test comes quickly, and if that is negative, then we can go for third.
Other thing is that most of the time the line between the grade 1 grade 2, the brain invasion itself is a criteria for grade.
Yes, sir.
So
See, brain,
how much significance will give?
See, I usually in at least my small experience, I can tell you, when there is a brain invasion, and I see other markers, KI has gone up, it's hypercellular, it is multifocal, brain invasions is coming through. You know, obviously there is something odd about it. And along with that, if its brain invasion is there, it itself qualifies for a bona fide grade 2. But there are tumors where, as Dr. Jalali has just arrived, he will tell us that just brain invasion alone in a otherwise bland looking meningioma has been questioned right now, because there are studies, they have done large scale studies on tumors that went exclusively only on brain invasions, bland appearing. They have done good, they have survived well, sir. So that is coming under question right now. My take would be, if it is brain invasion and if all other paraphernalia are there, it has mitotic activities there, it's gone 5-6, and there's necrosis coming in, and it has small cell change, especially necrosis associated with brain invasion, they are likely to do aggressively, sir. So that's where I take it more seriously. But usually they are, but occasionally I have seen tumors where they are just pushing into the pia. That doesn't count. It has to breach the pia and it has to go outside. So that's where.
Whole battery costs actually in a private sector.
It would be,
Because
depends.
we have a basal meningioma.
Basal meningioma, it's right now, I don't know there are any labs that are doing independently those set of markers.
Just a utopian or an actual figure, approximate figure, the whole battery.
It's
So
different.
that's what I was, when I was standing
Yeah.
there, that my comment was related to that.
See,
The cost of the surgery is becoming less than the cost of the.
testing is going on.
Are we really?
See,
and why am
I
not
would-
against the
yeah,
classification?
no,
I was
what
just
I'm-
making a small comment.
No, what
It was
I'm,
something like, it was just a remark. So are we missing, is there some evidence-based medicine, or is there absence of some evidence?
see,
Maybe they're just small jigsaw puzzles, and maybe 10 years down the line, we'll realize that 10 of them are merging together.
no, what my take is like this, sir. So whenever I have a tumor that is showing high KI index, just first regular simple IHC, humble IHC, we will do it. We'll take a call on that. EMA, which is formally present. There are some suggestions histologically to test where we have to go next. So that is what the baseline I'm trying to tell you, sir.
Surgeons tells you, I have removed 90% of tumor.
Ah.
And my impression was meningioma. What is the approximate value that a private sector pathology profile will take?
See, we all know that grade 1 meningiomas do very well. Yes, sir, that's what I'm telling. So EMA loss, then KI high, and the morphology. It's basic. That's my starting point.
Sir, 20,000.
Around 10,000 to 12,000, sir.
Thank you, Dr. Sushma. Thank you. So I would like to invite the next speaker now, Dr. Tejpal. He's the professor of radiation oncology at DMC Mumbai, and he's a general secretary of ISNOCON. And he is going to deliberate upon the optimal indications of adjuvant radiation in meningiomas and pituitary adenomas, finding certainty in uncertainty. Over to you.
Thank you, chairpersons. At the outset, I'd like to thank Indu, but this is a difficult talk to cover. Anyway, we all know that meningioma is the most common tumor of the CNS, and as Dr. Pathak said, it is not necessarily an innocuous disease. I'm not using the term benign, but this is historical data that shows that even the benign meningiomas, the 5-year relapse-free survival is 88%, and in anaplastic meningiomas, it is 28%. And this is more contemporary data from the NCDB, where the grading into benign, atypical, and malignant actually still holds true, with 5-year survivals slightly better for the malignant meningiomas, but certainly hovering around the 50% mark. Now, the stereotactic radiosurgery has been used for meningiomas. It is a precise treatment, planning, and accurate delivery of a large ablative dose of highly focused radiation with multiple beams in a single fraction. Now increasingly being fractionated up to 3 to 5 fractions using stereotactic localization techniques. And the pathophysiology of radiosurgical ablation is somewhat different from conventional radiotherapy. I would not go into the details of that. The other modality that we use, the other modality of radiation that we use is fractionated radiation therapy. And in the modern era, it is all image-guided intensity modulated radiation therapy, which is the preferred contemporary technique for fractionated RT. There are a number of platforms that are available for doing that, and no one platform is better than the other. Now, coming to the indications of radiation in meningioma, they can be used in asymptomatic patients where for small incidentally detected tumors to prevent new onset symptoms or deficits, reduce the risk of tumor progression, possibly some improvement in overall survival. That is questionable and debatable. Certainly more reliable evidence for symptomatic patients, both in the definitive, adjuvant, or salvage setting, to prevent new deficits, better local control, and reduce the risk of further progression. And in grade 2 and grade 3 meningioma, even an improvement in overall survival. So grade 1 meningioma, general management guidelines, you need to individualize the therapeutic approach. Most small incidentally detected meningiomas can be observed, and that's the preferred strategy. If therapy is indicated, surgical resection is the first choice, and gross total resection should be done wherever possible. Sometimes when either the surgeon is not willing to operate or the patient is not willing to undergo surgery, definitive radiation therapy can be used for incidentally detected meningioma, imaging defined, either fractionated RT or SRS. Of course, it is used in surgically difficult and challenging locations as well, such as optic nerve sheath meningioma and cavernous sinus meningioma. There is this systematic review and meta-analysis of SRS versus observation for incidentally detected meningiomas. And what they did show was, although small numbers, the risk of progression was significantly reduced with upfront SRS as compared to observation in incidentally detected meningiomas. In grade 1 meningioma, most of the time radiosurgery is used as can be used as an alternative to surgery. The deciding factors are size, location, age, and performance status of the patient, of course, patient preference as well. It is more commonly used as adjuvant for a small residue after resective surgery, and typically a dose between 14 to 16 gray, a single fraction is given. And as I said, increasingly now hypofractionated SRS in 3 to 5 fraction, 21 to 27 gray is being used. Fractionated radiotherapy is generally given for larger inoperable or recurrent tumors. Modern conformal techniques are advised, and the radiation therapy dose is between 50 to 60 gray in 25 to 30 fractions, depending upon the location and the OAR dosimetry. These are some data from of SRS in imaging, largely imaging defined meningiomas. And as you can see, the 5-year progression-free survival ranges above 90-95% for most tumors. There is certainly a role of adjuvant radiotherapy after surgery in grade 1 meningiomas that are not gross totally resected. Generally, grade 1 meningiomas after GTR are observed, but there are suboptimal outcomes in grade 1 meningioma with subtotal resection, and there is consistent benefit of adding adjuvant radiotherapy if a substantial residual disease has been left behind. Grade 2 meningiomas are much less common than the grade 1 meningiomas, but their risk of recurrence is significantly higher. Surgical resection again remains the mainstay of treatment, and gross total resection should be attempted. And the role of adjuvant radiotherapy has been controversial, but it has evolved over a period of time. This is the SEER database showing that patients who did not receive radiotherapy had better outcome as compared to patients who received radiotherapy. But there is a strong selection bias here because patients with poorer features receive radiotherapy as opposed to patients who did not receive radiotherapy. This is a systematic review of the role of adjuvant RT in grade 2 meningioma. It improves outcomes after STR, but does not impact on overall survival. And this data was recently, not so recently, 2017-18, this was published, where there was clear evidence of benefit of adding radiotherapy to after subtotal dissection in grade 2 meningiomas. So in grade 2 meningiomas, now the debate is whether to give radiotherapy after a gross total resection. So this was the first prospective study that the NRG RTOG did in meningiomas, and what they did was they divided them into 3 risk groups, and for the intermediate and high risk group there was radiation therapy. So excellent 3-year outcomes, very good PFS, only 2% local recurrence. Overall survival was also 96%, and no significant grade 3 or worse toxicity with postoperative adjuvant radiotherapy. A similar trial from the EORTC group actually showed that in around 78 patients that were enrolled, WHO grade 2 and WHO grade 3 meningiomas, again, the 3-year PFS outcomes were significantly better than the benchmark rate of 70%. So in grade 2 meningiomas, they demonstrated for the first time that there is a good outcome with less toxicity, and that has led to the launch of 2 randomized trials, one in the North America, which is the BN003, where gross totally resected grade 2 meningiomas are randomized to observation versus radiation therapy, which could be with either IMRT or protons, as well as the UK study, the Rome radiation versus observation in atypical meningiomas, which also uses a very similar trial design. Grade 3 meningiomas, the least common amongst the meningiomas, very aggressive biological and clinical behavior. Surgical resection followed by adjuvant radiotherapy is routinely offered. There is no proven role of systemic therapy or targeted therapy. The RTOG 053 also looked at the high risk, which included the grade 3 meningiomas, and they did show that the outcomes were not very good. Surprisingly, what they showed was that recurrent grade 2 meningiomas had worse outcomes than newly diagnosed grade 3 meningiomas, which is a bit surprising. Coming to the pituitary adenomas, they constitute around 10 to 20% of all brain tumors. 70% are secretory and 30% are non-secretory. The existing dogma regarding pituitary is that it is largely a surgical disease, and that is because of lack of evidence from randomized data, fear of re-excision in a previously irradiated area, fear of radiation-induced toxicity, and a lack of awareness regarding other treatment such as radiation therapy for in the neurosurgical community and the endocrinologists who deal with a lot of these patients. The indications for radiation therapy in pituitary adenomas are pretty much straightforward. A residual tumor not amenable to further safe resection. In secretory tumors, if there is biochemical evidence of persistent disease, if on histopathology or molecular testing you get aggressive disease biology, if it is a recurrent or progressive disease documented on clinical and imaging or biochemical grounds, and medically inoperable or patient refusal for surgery. Again, you could use radiosurgery or you could use fractionated radiotherapy. The selection criteria for pituitary radiosurgery is typically small volume disease and mandatory to have a safe distance from the optic pathway. 3 millimeter is not a sacrosanct criteria. Many people use 2 millimeters, but the further away it is from the chiasm, the safer it is. And generally, it should be a well-defined lesion on neuroimaging. Less than 10 gray to the optic chiasm, if that's not possible, then it's better to treat with fractionated radiotherapy. Again, a lot of series of radiosurgery for both non-functioning and functioning pituitary adenoma show excellent local control and also reasonably good endocrine remission rates. Even with fractionated radiotherapy, you get very good local control and with very little morbidity or toxicity. The toxicities of pituitary radiation typically either visual, new onset endocrinopathies, risk of cerebrovascular accident, second malignancies, cognitive impairment, and very, very rarely or occasionally radiation necrosis. I think that is the end, and I'd like to thank Dr. Indu and Dr. Aditya again for having me here.
Thank you. Thank you, Dr. Tejpal, for a very lucid presentation. In the interest of time, we can have one quick question from the floor.
Do you give radiotherapy for all grade 2 meningioma? Do you advise them?
So difficult question you're asking. Yeah. I didn't put those slides because of lack of time. So we had we analyzed our patients who had received upfront adjuvant radiotherapy in atypical meningioma and those who received radiotherapy at progression. And what we did demonstrate in that radiotherapy at progression was significantly worse than upfront adjuvant radiotherapy. So that is published in Practical Radiation Oncology in a series of 86 meningioma patients. Currently, we are part of the BN003, so we counsel the patients if they agree to be on the study, then whatever comes as randomization. We are also now increasingly doing the third promoter mutation and the 1P loss to take decisions in a gross totally resected. Subtotally resected grade 2, everybody receives radiotherapy.
But the grade 2, one is the atypical one. One other is that brain invasion variant.
No. So grade 2, brain invasion, histologically, brain invasion qualifies it as grade 2. So we would count as at grade 2.
And grade 1 with a high MIB.
No, so we don't give radiotherapy for that.
Problem with the WHO, I mean, Sushma, we have these frequent discussions in the meetings. The high power mitosis starts from 4 to 20. Such a wide range. Now, if you have a 4, that also is atypical. If you have 19, that also is atypical. That's a big variation. 4 sometimes in young, we try to avoid also if it's total, in that. And convexity meningioma more common actually, atypical rather than base of skull. So that is one. But if somebody has slightly higher, then absolutely we have to give upfront till the trial comes.
Yeah.
And MIP1 index has very poor correlation with prognosis. So we don't care about MIP1.
So the higher the mitotic count, more than 10, typically you will get some aggressive biological features. I mean, if you do 1P or...
I have reservation about giving radiation, especially in young patients, meningioma recurring after 5 or 7 years, which is again resectable. I think my choice and my take always is I'll resect it again and analyze the pathology and see. And then if it is needed, then I go for it, because if it recurred for 7 years, it's a benign thing. And you cannot radiate the surrounding dura, which is, that is one of the important criteria where you see on the imaging. 5 centimeters infiltration to dura. You cannot
so what I said was delay or salvage radiation, most of it is, 90% of it was after redo surgery. I'm not talking about just after redo surgery.
No, but upfront in atypical, there is a case, grade 1. Right. By the way, we can treat a lot of meningiomas, large meningomatosis, especially with proton, because you can delineate and spare the whole brain normally. And they are done well. There are, I think the 2 randomized trials will tell us what should we do.
Dr. Tejpal, pituitary adenoma post-operative. When do you give conventionally fractionated RT and when do you give hypofractionated?
So,
SRS?
Yeah, so most of the time, I mean, most of our experience is actually with fractionated radiotherapy. If it is away from the chiasm now, we are increasingly using the 5 fraction regimen, 25 grain 5 fraction. We are currently planned a randomized trial of 5 fraction versus conventional fractionation in secretory pituitary adenomas using time to remission as a primary endpoint. The local control rates would be very similar, and we are comfortable more with the 5 gray times 5 because then the optic chiasm dose, I mean the injury to the optic chiasm, that more or less is very, very tolerable.
I want to add the residual disease is the cavernous sinus.
Yeah,
so if the ipsilateral cavernous, unilateral cavernous sinus is involved versus bilaterally there is disease, then how do you?
So secretory, in secretory pituitary adenomas, we treat the entire sella, including both the cavernous sinus. So it doesn't depend which cavernous sinus is involved. For non-functioning pituitary adenomas, only the residual tumor is treated.
Thank you.
Generally, most of the time there will be small residue in the cavernous sinus after a standard TMDS endoscopy. Many times we see that we observe, and so what does the literature suggest? Whether to go for upfront or
I think that is a debatable question, but there is a series from Japan that did show that subtotally resected or a lesion, residual lesion left behind in the cavernous sinus, they can be followed up. Our preference is any residual tumor for non-functioning pituitary adenoma, we do upfront radiation therapy. And any persistent biochemical evidence of, lack of remission after surgery in secretory adenomas, we prefer to do upfront treatment. I think we need to, we'll discuss offline.
No, this is because I didn't intend, but I heard Dr. Jalali's statement about pathological criteria. So I wanted to put a question to the radiation oncologist community. Okay, I give you a tool, say for example, like today, if it can identify meningioma, which will recur after 1 year, after 3 years, after 10 years, after 7 years. Will your treatment change or waiting period will change, or you just want to know whether the tumor has got a recurrent potential or not? That is my first question. Second question, is your dosage or treatment plan any different from grade 2 and grade 3 meningiomas? So maybe the first question,
second question first.
You will get the answer of WHO criteria of what to 4 to 20.
Sridhar, second question first. So clearly there is a dose response relationship for malignant meningioma, but the problem is that in the brain, most of the time the doses are decided by the tolerance of the brain rather than by the disease. But still, most people would give 60. We now do a simultaneous boost of the gross residual node, gross residual node enhancing nodule if it is grade 3 meningioma. So we give 63 or even sometimes 64, 66 grade. The first question that you asked, if it is going to recur after 10 years, if you can be very confident about it, I would not irradiate.
And if it recurs after 7 years, 5 years?
See, that's 7 years, 10 years, 15 years.
Somebody has 19 out of 20 is going to recur in 1 year. I think sometimes you have to be humble to accept that WHO has to deal with this. You cannot do 4 mitosis.
What I'm trying to say is the criteria tells you that when you have more than 4, the chance, the potential for recurrence is there. So the period of recurrence, we may not really speculate about it. But when you're saying malignant meningioma, to have relapse within a year, or like predominantly like in high grade sarcoma where you have a dosimetry differences there, that has been observed for it, whatever, this 20. It's nothing like a magic thing at all. But as a pathologist, when we see, you can ask Dr. Sushma also, when you see around more than 15 mitosis and all, we also will be very little bit diligent whether don't hold into grade 2. We take other features into the picture and try to add on to their clinical picture as grade 3. But we need to have some guidelines or reference this thing about to follow that. That's the criteria.
I think they're asking us to stop.
We need to stop this debate, and the heated debate also proves that it is not a good tumor at all. The topic was good tumor. So now I call upon Dr. Ashish to give us some take-home pulse.
Yeah, most of it is done. So genetic landscape has been discussed, and we know that NF2 is the main gene which is the mostly which affects, and we have got all these genes, already heard about it, so I'm not going into those. And we know that methylation has a better prognosis. We have seen for the recurrence, distinct intracranial location, all these things have anything to do with genes. And now we have got the TERT mutation, which has come into the picture. So I'm not a pathologist or molecular biologist, so I understand none of these. Now they have shown that 55% of these would have NF2 mutation. So that's something to remember. As a clinician, these mutations have some relevance. It's not perfect. If you have got the TRAF and AKT1, then they are mostly located in the anterior fossa, the medial part of the middle fossa, anterior calvarium, and of course, they are usually meningothelial or transitional meningioma. And if you have got the TRAF7 and KLF4 mutation, they are usually in the lateral middle fossa, median posterior fossa. So they have made some locations, which I don't think is sacrosanct, but yes, and they are usually of secretory meningioma variety. This is a secretory meningioma, and that fits in with what I said a little bit ago. And this lady is doing well at complete excision.
Now, meningiomas, as I said, first of all, as per me, they are not benign. You can't call them benign, you can give some other term to them. That's a different story. And they're so diverse, they are fascinating but frustrating also. Intraventricular meningiomas are totally different ones. They have got NF2 mutation but lack the other genetic mutation. So they're a different variety. So, you have to also consider them as a different category, not put them in the same basket. But about spinal meningiomas, they're different. They're a different class. They have got different genetic mutations. So, saying grade 1 to all of them and how they will behave is an important question, and we don't have answers to this. So I'm just raising questions to put forward to you. And the question which the patient asks, now coming to the patient, can you get rid of the tumor 100%? The answer has to be always very clear to them. And we had this 1957 Simpson who made that excision classification. In those days, mind you, there was no MRI, no molecular biology, and they didn't have CT scan also. And yet they did it, and he said, if you remove the meningioma along with the underlying bone and the dura, even then he says the recurrence is 9%. So you have gone to the root, you've removed the so-called root of it, and yet it comes back. So that's another problem. And if you not remove the root, it's 19%. And if you have just taken it out without touching the root, it's 29%. I'm making it simple. Root means, the dura and the other. And of course, if you're just taking a biopsy, it is going to come back. So this is very important. So at that time, mind you, there was no CT scan, no MRI, no molecular biology, nothing. So this is, you can see how this tumor is the dural extension to the other side. Now we're going to run after everything here. I don't know. So the Simpson's grading of excision of tumor has, how much is it got prognostic value is one thing. We keep on talking Simpsons in the surgical conferences, but then we don't know the impact of doing a good excision rather than going for every bit of it. So there are fallacies. As I said, that it was a visual assessment in those days, and it is notoriously inaccurate. And majority of the studies using this grade system show that post-operative MRI surveillance is a better tool, which will tell you how much is there, whether you need to follow up, how to follow up. The MRI is a very good tool, and you can follow them up and decide. All those questions raised can be decided on how you see the tumor behave in the follow-up and make a decision. The infiltration and the proliferation potentials are important here. So have I removed the whole tumor here? It was a paraphile cell tumor. It looks nice, but I'm not sure whether I've removed everything. So the goal of meningioma surgery is that maximal safe resection with minimal morbidity. That's number one. And go for as much as safe resection you can do. You can use various tools, intraoperative MRI, molecular tagging, blah, blah, blah. And ultimately, they did meta-analysis. Now, the value of molecular markers and Ki67, I believe, is very, very important, and we do it in all the cases. And if the Ki67 is more than 4%, you must be very cautious and follow these patients clearly. I don't know that this 4% is the correct figure, but the meaning is that if the Ki67 is high, you better be careful and follow them up very religiously and tell the patient that you have a chance of recurrence. How much chance, I don't know, but we'll look into it. If it recurs, we'll take care of it. So there are various predictive factors for recurrence. Large tumor. Actually, the tumor larger, it tries to get adherent to the arachnoid. You feel that there's invasion. Edema is one of the factors. Osteolysis, cortical penetration, signal T2 intensity in the pile cortical arterial supply. If it is there, they say that it's a bad prognostic sign, recurrence is good, and all those things. Tumor size is important, and it can infiltrate or adhere to the arachnoid. Tumor location is very important, because in many deep city locations, you can't go for what is so-called Simpson's grade 1 excision. So subtotal resection, posterior fossa location, nuclear atypia, elevated MEB index, and MEB index more than 4.5% are bad prognostic indicators. Another important thing, radiation-induced meningioma is totally different category. And this is one of the commonest tumor after radiation, and it can occur after 10 to 30 years. So, you have to remember those. So children receiving even 1 to 2 gray of radiation have 9.5-fold increased risk of developing meningiomas in the long-term life. So there is a different kind of mutation here also, but they have got NF2 mutation, and they are a different category. So you have to remember that thing. We don't consider this as much. Familial meningiomas, totally different again. And there are so many other genes involved in it. I'm not going to do that. Hormones in meningiomas. If the breast cancer patients have a high risk of meningiomas. So as I said, meningioma is a varied subject. It's a total subject or textbook altogether. Genetic syndromic meningiomas. Then again, it's a Pandora box. And you've got so many syndromic varieties of meningiomas. So it will take a long time to go into this. And this is neurofibrinosis patient. You see how many meningiomas everywhere. And we had to go on removing those which are symptomatic. N-plaque meningiomas. We don't understand the molecular biology of these. This is again different category. We don't know. So all this, so the recurrence is classified as a demographic, environmental, genetic, imaging, neuropathological, neurosurgical. So that's the way we can consider them, they classify the recurrence in meningiomas. So conclude, meningioma is not a single entity. Don't be fooled. The pathogenesis involves different genetic aberrations with diverse pathways. The progression behavior is very diverse. Despite so much progress in modern medicine, in molecular biology, in genetics, recurrence-free treatment is still far from reality. So no matter, you should not have this meaningful if that I am the best and you are the best. It's you are just, we don't know about meningiomas, to be very honest. Thank you very much.
Thank you, sir. Do we have Dr. Kanika Sharma Sood for her comments and final take-home pulse?
First of all, I thank Dr. Indu for the opportunity for giving these pearls of wisdom, which I think have already been put forth by Dr. Tejpal beautifully. Most controversies have been rested. What were these uncertainties? So there were uncertainties in context to the indications, the techniques and fractionation when we talk of the meningeal and the pituitary tumors. And indications, we felt that probably the molecular biology is going to add to our tools. But yes, it is giving us a risk stratification, as you could see the landscape presentation on mutations given by Dr. Sushma, that these markers are going to give us a clue that which patient is going to fare poorer. And probably that answer that whether we would wait to radiate or to upfront offer radiation would be made clearer by these risk modulations, which would be achieved by the molecular markers. Third, yes, it is a marker to identify grade 2 versus grade 3. But as of now, in the risk stratification, it does not hold value. Having said that, we do have this beautiful landscape of mutational analysis, which is telling us where our patient would fall into the risk stratification. But till date, I think we are still following the age-old Simpson grade when we take a call in terms of deciding whether patient needs radiation or not. So I think Simpsons has been discussed repeatedly in the previous talk, so I will not elaborate more here. But this is how it factors into our decision-making. So the guidelines mostly take into account the amount of resection and the grade of the tumor. And this is the IANO guideline of 2021, which beautifully says that if there is a mass effect and the therapeutic intervention has been done, but that intervention has been not a gross tumor resection, then there would be an indication for radiation based on the grade as well. For the grade 1, if there is a full resection, observation, if there is not a GTR and it's a symptomatic disease, then offer treatment or observation if patient is not symptomatic. Grade 2, again, options of observation and RT, because as you could see in Dr. Tejpal's slides, grade 2 was the area where there was no benefit of OS in certain series. Grade 3, I think there is not much of controversy onto that. So this would be the summing up of the guidelines in terms of the indications for radiation. This again, Dr. Tejpal has beautifully told that what is the benefit radiation has to offer in these situations. In an asymptomatic patient who has been detected incidentally, it will prevent the disease progression, it will prevent the development of new deficits, and then of course OS is not very well defined. Whereas for symptomatic patients, it has a definitive role. I will not reiterate the factors. For pituitary adenomas, things are more black and white. There are lesser grays. He has already said that you are to radiate tumors which are residual and are not amenable to further resection. But if there is a biochemical evidence of disease which is not controlled by your medical management, aggressive disease biology, recurrent progressive disease, and inoperable patients as well. Technique-wise, I think it has been a very, very concise overview which he has given you, that there are two ways to treat these tumors. You can go by fractionated treatment or by SRS. The premise is the location of the tumor, the predictability that whether your optic apparatus will get less than 10 gray would be by the location and the vicinity to the chiasm, which some say 3 millimeters and some say 5 millimeters. Apart from that, the size of the tumor also dictates. But very important pearl to take home is that the well-defined lesion is the one which you would prefer to go by stereotaxy vis-a-vis the fractionated treatment. Fractionation schedules, I think he has beautifully covered that there is a dose response establishment, but the lower grade tumors go for low dose, but whereas grade 3, you may want to escalate beyond 60 gray as well, based on the studies by the NRG group. Pituitary adenomas, functional versus non-functional, there has been dose response curve evaluation, but there has been a very good more than 85 to 95% disease control by 45 gray and above. For SRS based, 16 gray is what has been established. I will not walk through these slides again in interest of time. So this is what the fractionation schedule is of current practice. One has to be cognizant of the toxicities and taking into account that the dose fractionation has to be further refined. So I'll just end by saying that uncertainties do pave paths to certainties, and we have much more to know with these new molecular markers coming into picture. Thank you so much.
Most of the pituitary tumors will have a little bit of residue, I tell you. 80 to 60%. If it is converted to a microadenoma, and it is typically non-functional. When I say non-functioning, no FSH, no LH. Even immunohistochemistry should not show FSH, LH. Those are pure null cell tumor. They don't grow. And I have patients for 15 to not one, at least 50 of them. They never grow, and the patient outgrows. So I won't give any radiation to them. I would just observe them. And if the young ones they regrow, I'll go and remove it again and then think of radiotherapy if not. So again, giving upfront radiotherapy in a so-called non-functioning pituitary tumor is again something I would still ponder upon, not straight away accept it. I would avoid radiation in a young person. That's the basic thing.
Thank you. So we come to the end of the session. Hand over to the organizers.